Hello, everyone, and a warm welcome to today's edition of Patcast. Today is July 27, 2020. I'm Rifat Mannan in Philadelphia, and I'm remotely joined by my good friend Emilio Madrigal, who is in Boston. Today, we are very excited to welcome Dr. Olka Basturk, who is Associate Attending Pathologist at Memorial Sloan Kettering Cancer Center in New York, and she's also the Vice President of the Pancreatoblastoma Pathology Society. Today, she's going to present a talk on pancreatobiliary pathology, of course, and the title of her talk is Solid Tumors of the Pancreas. As always, please feel free to post your questions or comments on YouTube and Facebook chat windows, and Dr. Basturk will be happy to answer them towards the end of the session. And thank you, Dr. Basturk, for joining us today. Over to you now.
Thank you, Rifat, for the nice introduction, and thank you and Emilio for creating podcast. I believe it's a very strong educational tool, especially nowadays where we don't have any in-person meetings, so we appreciate your efforts. As Rifat mentioned, today we are gonna talk about the solid tumors of the pancreas. And based on their gross appearance, solid pancreatic lesions can be divided into two major categories. The first one is serous and ill-defined lesions, and this category includes pancreatic ductal adenocarcinoma and chronic pancreatitis. The second category is fleshy and well-demarcated lesions, and this category includes neuroendocrine neoplasms, Acinar cell neoplasms, pancreatoblastoma, and solid pseudopapillary neoplasm. We are going to start with pancreatic ductal adenocarcinoma. As we all know, pancreatic ductal adenocarcinoma is the most common tumor of the pancreas, constituting more than 85% of all pancreatic tumors. It's usually seen in older patients, and there is no gender predominance. One thing that is quite underappreciated about pancreatic ductal adenocarcinoma is that it is the third leading cause of cancer deaths in the United States, and it's expected to be the second in the near future. Unfortunately, it has a very dismal prognosis, with a 5-year survival being less than 5%. And the rate of mortality is almost equal to the rate of incidence. Another thing about this pancreatic ductal adenocarcinomas is that it's one of the most common source of carcinoma of unknown primary, which tells us a lot about this tumor. First of all, it is difficult to diagnose histologically, and by the time we diagnose it, it's often widely disseminated. These tumors are usually located in the head of the pancreas, and they are grossly ill-defined and firm lesions, and their cut surfaces usually tend to white and firm. Microscopically, they are usually gland-forming epithelial neoplasms, and degree of gland formation is proportional to the degree of differentiation, ranging from well-formed glandular structures to individual infiltrative cells or solid sheets. However, pancreatic ductal adenocarcinoma is notorious for its often deceptively benign appearance, which means distinguishing ductal adenocarcinoma from chronic pancreatitis, in other words, distinguishing malignant glands from benign ducts, can be very difficult, especially in small biopsies and frozen sections. However, there are a number of features that are or that can be useful in this distinction. The first one is distribution of the ductal structures. Is the process lobular or disorganized? The benign ducts seen in chronic pancreatitis usually reveal a lobular architecture. Tightly packed benign ducts are evenly spaced, evenly sized, and evenly shaped. And when you look at the contours of individual ducts, it is usually smooth, and even the overall architecture is usually smooth. In contrast, malignant glands are haphazardly distributed. They have different shapes and different sides, and when you look at the individual contours, they are very irregular and angulated. In fact, this lack of lobularity can be appreciated in at least some of the biopsy specimens as shown here. This is clearly malignant. Another useful feature is abnormal localization of the ductal structures. If you see ducts in perineural spaces, this means carcinoma. Perineural invasion is very common in pancreatic ductal adenocarcinomas. In fact, if searched carefully, it can be seen in about 80% of all resected tumors. It is usually located in the peripancreatic adipose tissue or nerve trunks around the common bile ducts. Unfortunately, these areas are not the targets of biopsy specimens or frozen sections. Moreover, carcinoma cells, when they invade the nerves, they become more glandular and more innocent looking, as shown here. So it may be difficult to recognize. It should also be kept in mind that benign islets can wrap around the nerves. Especially in chronic pancreatitis, residual islets can be intimately admixed with nerves, mimicking perineural invasion. When in doubt, immunohistochemical stains, especially chromogranin and synaptophysin, can be used to determine the nature of the cells. Band of tissue around the ductal structures is also an important clue. Vascular invasion is common, just like perineural invasion in pancreatic ductal adenocarcinomas, and it's seen in about 60% of the resection specimens. In fact, if you sample the pancreatic adipose tissue extensively, this number can easily increase up to 80%. As in perineural invasion, carcinoma cells, when they invade the vascular spaces, they become more innocent looking, and sometimes they may even replace the entire endothelium and may form ductular or glandular structures mimicking benign ducts. However, please remember that the benign ducts are not supposed to be by themselves within the adipose tissue. Plus, subtle architectural or cytologic abnormalities, as well as the muscular nature of the tissue around this glandular or ductular structures, are clues for their malignant nature. Ducts next to medium-sized thick-walled blood vessels. In the normal pancreas, small or medium-sized ducts are located within the center of the lobule. In contrast, muscular blood vessels are located at the periphery of the muscles, so anatomically they are separated. However, malignant glands can do whatever they want and can, of course, violate this anatomic organization and can be seen immediately next to thick-walled vessels. Therefore, if you see even very innocent, very bland-looking glandular structures immediately next to these thick-walled vessels without significant stroma or accompanying acini, you should favor carcinoma. Individual glands in the adipose tissue. Normal acini and especially normal islets are often seen in the adipose tissue, especially in chronic pancreatitis if the pancreas is atrophic. However, as I just mentioned, benign ducts are not supposed to be seen by themselves without accompanying tissue or accompanying other pancreatic elements such as acini or islets within the adipose tissue. Therefore, if you see naked ducts, this is what we call individual glands within the adipose tissue, we call them naked ducts. If you see naked ducts literally kissing the adipocytes, then they are also most likely malignant glands. Another useful feature is the architecture of ductal structures. Benign ducts that are located in the center of this picture have smooth and undulating contours, and their lumina is usually compressed, as shown here. In contrast, malignant glands that are located at the periphery of these pictures have irregular, angulated, and sometimes even incomplete contours. And their lumina is usually open. And necrotic debris in the lumen also is a clue for malignancy. And in some pancreatic ductal adenocarcinomas, there is a striking intracytoplasmic vacuolization, which means there are multi-cell size vacuoles. Some of them can even have mucin in it, compressing the nuclei towards the periphery and creating this cribriform and sometimes signet ring-like appearance. Of course, hyperchromasia and pleomorphism is also evident in this pattern. And finally, stromal changes. As we all know, pancreatic ductal adenocarcinoma is notorious for its desmoplastic stroma. It may be difficult to describe, but once you see it, it's easy to recognize. Of course, no need to mention that none of these features are absolute, and they should be used in combination and with caution. In fact, in resection specimens, we don't even need them. We don't even systematically search for those features. But biopsy specimens, and especially frozens, remains one of the most challenging specimens for the surgical pathologist. And in those specimens, it may be the presence of this subtle, like very focal feature that allow us to distinguish benign ducts from malignant glands. In other words, benign processes from pancreatic ductal adenocarcinoma. Moving on to pancreatic neuroendocrine neoplasms. As we all know, the current 2017 neuroendocrine and 2019 gastrointestinal WHO classifications regard the entire spectrum as neuroendocrine neoplasm, encompassing both well-differentiated neuroendocrine tumors and poorly differentiated neuroendocrine carcinomas. We'll discuss the well-differentiated pancreatic neuroendocrine tumors, or PanNETs, first. These are rare neoplasms. They constitute only 1 to 2% of all pancreatic neoplasms. Their association with MEN and less frequently with VHL syndrome is well established in the literature. Although they can be seen at any age, they are more common in adults, older adults, and they can be seen in anywhere in the pancreas, but most of the resected and non-functional PanNETs are located in the head of the pancreas. Grossly, PanNETs are usually solitary and well-circumscribed lesions. Their cut surfaces tend to white, and it could be fleshy or firm depending on the amount of the stroma. And about 13% of pancreatic neuroendocrine tumors present as at least partially cystic lesions due to the central degeneration, as shown here. As recently reported by a comprehensive clinical pathologic analysis, morphologic spectrum of the PanNETs is much wider than appreciated. In addition to the classical nested and trabecular patterns as shown here, one might see a vast assortment of different growth patterns in PanNETs. Most of these tumors are solid cellular tumors, but some of them can have abundant sclerotic stroma as shown here. Some PanNETs actually have a population of scattered small ductular structures. Some of these ductular structures are even surrounded by neuroendocrine nests, and the overall appearance is similar to what we call ductular insular complexes in chronic pancreatitis. However, recent molecular studies have shown that these ductular structures are not monoclonal, meaning they are not malignant. They are simply entrapped normal ducts of the pancreas, and only the neuroendocrine component of this lesion is malignant. And those entrapped ducts are highlighted by CK7 stain in this picture. Occasionally, PanNETs can reveal striking nuclear pleomorphism as illustrated here, accompanied by abundant eosinophilic stroma. And it's important to know the existence of this phenomenon because most of these tumors are actually misdiagnosed as poorly differentiated or high-grade adenocarcinomas. However, despite their scary appearance, and please look at this cell, it's multinucleated, it's very hyperchromatic, it's huge, it's very scary, but this is just a pleomorphic neuroendocrine tumor, and biologically it's not any different than other conventional pancreatic neuroendocrine tumors. However, the clinical pathologic analysis paper I just mentioned also revealed that certain variants of the pancreatic neuroendocrine tumors are actually biologically more aggressive compared to the conventional neuroendocrine tumors. I'm going to talk about 3 variants. The first one is rhabdoid variant. This is actually a very nice example of rhabdoid pancreatic neuroendocrine tumor. The tumor cells have eccentrically located hyperchromatic nuclei, and their cytoplasm is glassy looking, almost like an inclusion. And they are very similar to signature cells, but these tumors do not, of course, have any mucin within the cytoplasm. In fact, the cytoplasm is filled with intermediate filaments and dense core granules. So unless you are familiar with this variant and do the stains, you may easily misdiagnose this tumor as poorly differentiated or signature cell adenocarcinoma. Another challenging variant is so-called lipid-rich variant. This variant is called lipid-rich because the cytoplasm is filled with these clear lipid vesicles, and then overall appearance is very similar to renal cell carcinoma or adrenocortical carcinoma. In fact, in our consultation materials, we see that most of these tumors are misdiagnosed as metastasis from those organs. And they are also biologically aggressive. And the last biologically aggressive variant of PanNET is the so-called oncocytic variant. These tumors are characterized by these large eosinophilic and granular cytoplasm, as well as centrally located, very prominent single nucleoli. Overall appearance is very similar to hepatocellular carcinoma, and unless you do the immunohistochemical stains, you may not be able to distinguish these tumors from hepatocellular carcinomas. So as I mentioned, pancreatic neuroendocrine tumors can have a lot of morphologic variants, and it's important to know their existence to avoid misdiagnosis. And of course, in majority of the cases, you are gonna need immunohistochemistry to prove the neuroendocrine nature of the tumors. How about the grading of neuroendocrine tumors? The current WHO classifications recommends grading these tumors based on their mitotic activity and Ki-67 proliferation index. Accordingly, tumors that have less than 2 mitotic activity per 10 high power field or up to 3% Ki-67 proliferation index are graded as grade 1. Tumors that have more than 20 mitotic figures or higher than 20 Ki-67 proliferation index are graded as grade 3, and anything in between is graded as grade 2. Also, please keep in mind that the mitotic rate and Ki-67 proliferation index-based grades can be discordant, and when they are discordant, you should go with the higher grade. So sounds simple, right? But the more we use this grading system, the more we realize there are some problems. Number one problem, how are we going to determine the Ki-67 proliferation index? In other words, how are we going to count it? Of course, there are several counting methods. The first one is counting number of cells by live microscope. Personally, I have never been successful doing so. Whenever I try to count cells on the microscope, and remember WHO recommends counting at least 500 cells, either someone knocks on my door or my phone rings. If nothing happens, I sneeze and I lost track. So I can't do this successfully. And I believe a lot of pathologists are the same. That is why a lot of people stop counting the cells and simply doing eyeballing, which is also known as guesstimating. But is it accurate? Unfortunately, no. Eyeballing is far from being accurate. And of course, if you have a very obvious well-differentiated neuroendocrine tumor with like a few positive Ki-67, a few positive cells, or clearly small cell carcinoma, you can simply do eyeballing. But please remember that about 60% of the PanNETs have an index close to the categorical cutoffs. So eyeballing is not acceptable for those 60%. And Memorial Group recently showed that eyeballing illustrates striking inter-observer variability. So basically, eyeballing is not an option. Of course, you can use one of those fancy softwares, and you can count the number of cells by digital image analysis. But unless you are using a very good one, most of those software unfortunately also counts lymphocytes, endothelial cells, hemostatin, anything brown. So they may not be accurate. So what do we do? Well, at Memorial, we do manual counting of the cells on a printed photograph. So what we do is, since each pathologist have a camera and printer in their offices, we take a picture of the hotspot on 20x, so we would have enough cells, and then we print and then count manually. This is very accurate. It's easy. Once you get used to it, you can do it in less than 5 minutes, and you may even take a break if necessary. So that's what we do at Memorial Sloan Kettering Cancer Center. And in their comparative analysis of 4-counting methodology, Dr. Reed and colleagues have shown that this manual counting on a printed photomicrograph is the most applicable approach because it's practical and accurate in daily life. And in case you are wondering, when we print, we count all the brown cells. We don't just count the very dark ones. We count all the brown cells, all the brown tumor cells, of course. Poorly differentiated pancreatic neuroendocrine carcinomas. Primary poorly differentiated neuroendocrine carcinomas of the pancreas are very rare. And as far as we know, unlike PanNET, they are not associated with any syndrome. They are usually seen in older patients in the head of the pancreas, and they are quite large tumors. In a series of 44 cases, the median size was 4 centimeters. Grossly, these tumors are they have ill-defined borders, and they are usually fleshy tumors with areas of hemorrhage and necrosis. Microscopically, just like any other organs poorly differentiated carcinomas, they have 2 types, small cell and large cell. Small cell carcinomas usually present with large areas of necrosis, and on high power, you can see that they have very high NC ratio, and hyperchromasia and pleomorphism is striking. In contrast, large cell type is characterized by much lower NC ratio because the cells have more abundant cytoplasm, and they can also have very prominent single nucleoli. And one might also see glandular or pseudoglandular structures in large cell neuroendocrine carcinoma. In fact, both small cell and large cell type neuroendocrine carcinomas can be associated with non-neuroendocrine neoplasms. The current WHO recommends mixed neuroendocrine, non-neuroendocrine neoplasm, or MENAN, for these tumors. And in these MENANs, the 2 components can be distinct, as shown here. This is a small cell carcinoma on the top, and at the bottom we have a clear-cut ductal adenocarcinoma. But in other MENANs, the 2 components can be very intimately admixed, as shown here. And this is another example of MENAN in which the poorly differentiated neuroendocrine carcinoma is small cell carcinoma, and non-neuroendocrine component is a squamous cell carcinoma. These are quite rare tumors. By definition, all poorly differentiated neuroendocrine carcinomas are grade 3 because they have more than 20 mitotic figures per 10 high power field, and their Ki67 proliferation index is higher than 20. In fact, their average Ki67 index is much higher than 20%. In our series, large cell carcinomas had average 66%, and small cell carcinomas had average 75% Ki67 proliferation index, which actually brings us to problem number 2. So we said both grade 3 well-differentiated neuroendocrine tumors and poorly differentiated neuroendocrine carcinomas have higher than 20 Ki67 proliferation index. Then are they really that different? Well, recently we have shown that when we looked at their survival, when we compared to grade 2 well-differentiated neuroendocrine tumors, grade 3 well-differentiated neuroendocrine tumors, and poorly differentiated neuroendocrine carcinomas, we have shown that there is no statistically significant difference between the grade 2 and grade 3 well-differentiated tumors. Their prognosis is similar. In contrast, there was a statistically significant difference between grade 3 well-differentiated neuroendocrine tumors and poorly differentiated neuroendocrine carcinomas. So these are prognostically different tumors. Moreover, In another study, including 305 patients, not only pancreatic poorly differentiated neuroendocrine carcinomas, but also other like gastrointestinal neuroendocrine carcinomas, the authors shown that if the Ki-67 is less than 55%, these tumors do not respond to platinum-based therapy very well, but still their overall survival is better. In contrast, if the Ki-67 is equal or higher than 55%, then these tumors respond very well to platinum-based chemotherapy, but unfortunately, they also come back very quickly and their prognosis is bad. So obviously, these tumors also have different treatment response. And finally, there are a number of studies. I just illustrated a few examples here. There are a number of studies showing that well-differentiated neuroendocrine tumors and poorly differentiated neuroendocrine carcinomas are genetically very different. First of all, poorly differentiated neuroendocrine carcinomas are similar to pancreatic ductal adenocarcinomas because they frequently show mutations in the KRAS, CDKN2A, SMAD4, and P53 mutations. In contrast, well-differentiated tumors do not have these mutations except rare cases, about 4% with P53 mutations, and these P53 mutations are different than the ones we see in the poorly differentiated neuroendocrine carcinomas. Moreover, well-differentiated neuroendocrine tumors often have MEN1, DAX, or ATRX mutations, but poorly differentiated carcinomas do not have these mutations. Instead, they commonly have RB mutations, which is not a genetic feature we see in a well-differentiated neuroendocrine tumor. So as you can see, these are genetically also very different tumors. And that is why the current classification, WHO classification systems decided to divide the 2010 classifications neuroendocrine carcinoma category into two different categories: well-differentiated grade 3 tumors and poorly differentiated grade 3 carcinomas. This is definitely a step forward, but is it enough? Well, how are we going to distinguish G3 well-differentiated neuroendocrine tumors from poorly differentiated neuroendocrine carcinomas? Well, for most of the tumors, morphology is typical, and you don't have any problem classifying the tumors into one of these categories. But there is a subset of tumors that the morphology is not very obvious. You cannot decide if the tumor is well-differentiated or poorly differentiated based on morphology only. We call these tumors ambiguous tumors. This is actually one of those cases. Clearly, it's a high-grade neoplasm with frequent mitotic activities. But is this a grade 3 well-differentiated neuroendocrine tumor, or is this a poorly differentiated large cell type neuroendocrine carcinoma? Based on morphology, we cannot tell. And our group actually showed that even the experts who deal with these tumors on a daily basis cannot agree on classifying these tumors based on morphology only. So what do? When we have a tumor like this, we examine the entire specimen, not only the specimen at hand, but also if there are prior biopsies or prior materials, we examine those specimens to see if there is a lower grade, grade 1 or grade 2 well-differentiated neuroendocrine component. Because if there's a lower grade well-differentiated neuroendocrine component, that means the tumor at hand is grade 3 well-differentiated neuroendocrine tumor. In contrast, if there's a coexisting non-neuroendocrine carcinoma, then we favor poorly differentiated neuroendocrine carcinoma because non-neuroendocrine carcinomas are not usually combined with well-differentiated neuroendocrine tumors. But unfortunately, for most of the specimens, we don't have this luxury. So what do? We do, every pathologist do, we do the immunohistochemical stains. And of course, one stain is not enough, so we do a panel of immunohistochemical stains. We do P53, RB, SMAD4, DAX, and ATRX. And if the tumor shows loss of RB or SMAD4 expression, and I cannot emphasize the importance of loss, because if the expression is retained, it doesn't help you. If it is lost, only if it is lost, then it means poorly differentiated carcinoma. In contrast, loss of DAX or ATRX expression favors well-differentiated neuroendocrine tumor. I want you to be careful with P53 because usually, although its overexpression usually means poorly differentiated neuroendocrine carcinoma, as I just mentioned, a small subset of well-differentiated neuroendocrine tumors can also show P53 abnormalities. So P53 is not reliable by itself, unlike RB, SMAD, or DAX or ATRX. So this is the summary of algorithm we use in our daily sign-outs. If we have a high-grade neuroendocrine tumor with tumor necrosis, increased mitotic activity, or high Cas67 proliferation index, we truly examine the current and additional pathology material. And if there is a lower grade well-differentiated neuroendocrine component, we favor G3 well-differentiated neuroendocrine tumor. If there is a conventional adenocarcinoma or squamous cell carcinoma component, we favor poorly differentiated neuroendocrine carcinoma. If these are not helpful, and usually we don't have these features for most specimens, then we do immunohistochemical studies. Loss of DAX or ATRX means well-differentiated neuroendocrine tumor. Loss of RB or SMAD4 expression means poorly differentiated neuroendocrine carcinoma. Moving on to pancreatic acinar cell neoplasms. Pancreatic acinar cell neoplasm can be pure or mixed. If they are pure, they can present as a solid tumor or intraductal papillary neoplasm. If they are mixed, they can be mixed acinar neuroendocrine, mixed acinar ductal, mixed acinar neuroendocrine, and ductal. Pure acinar cell carcinomas are rare, constituting 1 to 2% of all pancreatic neoplasms, and they are usually seen in older patients, and they are more common in males. The patients usually present with non-specific symptoms such as abdominal pain, vomiting, weight loss, and since most acinar cell carcinomas do not obstruct the common bile duct, jaundice is not very common. However, about 10 to 15% of the patients present with lipase hypersecretion syndrome. This syndrome is characterized by subcutaneous fat necrosis, polyarthralgia, and eosinophilia, and it is the result of excessive lipase secretion by the tumor into serum. The patients may also have high serum alpha-fetoprotein levels. The tumors are usually large with a mean size of 7.8 centimeter. Grossly, the tumors are well circumscribed as shown here, and they have tan to yellow and lobulated cut surface, and you can see foci of hemorrhage and even necrosis, especially in old tumors. Microscopically, these are markedly cellular tumors with very little stroma, and the periphery of the tumor is usually well circumscribed as shown here. Acinar cell carcinomas can show different growth patterns. In solid growth pattern, the tumor cells are arranged in nests or diffuse sheets separated by these delicate fibrovascular stroma, and the tumor cells have a variable minimal to medium amount of cytoplasm. The true and characteristic acinar pattern is unfortunately seen only in a subset of the cases. You may not see in all acinar cell carcinomas, but when this pattern is characterized by back-to-back small acinar structures as shown here. And some of these acinar structures actually can look like rosettes. Although individual glands surrounded by stroma is rare in acinar cell carcinomas, so-called glandular pattern is characterized by these acini with dilated lumina, as shown here. And rarely, acinar cell carcinomas can present with trabecle formations as illustrated here. At any rate, one of the characteristic features of these tumors are these eosinophilic granules, and they are usually more prominent in the typical acinar growth pattern. Another example of these, acidophilic or eosinophilic granules. But please remember that the amount of these acidophilic granules vary between the cases, and sometimes even within the same case, within the different areas of the same case. DPAS stain might be helpful by highlighting these granules, but nowadays nobody is doing this stain. Everybody is directly using the immunohistochemical stains. Intraluminal acidophilic amorphous materials and crystals, and these are simply enzymatic condensations, are also common in acinar cell carcinomas. And of course, round, uniform, or oval, uniform nuclei and very prominent cherry red-like nucleoli are characteristic features of acinar cell carcinomas. But just like acinar structures or acidophilic granules, you may not see this feature in all acinar cell carcinomas. If it is there, it's very helpful. If it is not there, well, there's nothing we can do. Although mitotic activity is variable, most of the acinar cell carcinomas are actually mitodically very active. Of course, the diagnosis depends on demonstration of acinar differentiation, and there are a number of acinar markers that you can use for this purpose. Trypsin, chymotrypsin, and BCL10 are very specific and very sensitive markers that can be used to diagnose acinar cell carcinomas. This is an example of trypsin positivity in an acinar cell carcinoma. And please keep in mind that scattered neuroendocrine marker positive cells are very common in pancreatic acinar cell carcinomas, but unless a substantial portion of the tumor is positive for those markers, we do not classify tumors as mixed just because there are some scattered chromogranin or synaptophysin positive cells. And of course, the tumors can be positive with alpha-fetoprotein, but it's very non-specific. By molecular analysis, it has been shown that acinar cell carcinomas lack majority of the ductal differentiation markers, such as mutations in KRAS P16 or DPC4 genes. However, about half of the tumors actually reveal allelic loss of chromosome 11p, and about 20% of the tumors are characterized by altered Wnt signaling, including inactivating mutations in APC and activating mutations in beta-catenin genes. More recently, it has been shown that about 25% of acinar cell carcinomas have recurrent rearrangements involving BRAF and RAF genes, and about half of the tumors are characterized by inactivation of DNA repair genes, including BRCA1, BRCA2, ATM, and as such. Is this important? Yes, actually, this is a very important feature because it has been shown that acinar cell carcinomas with recurrent arrangements of BRAF and RAF genes are actually sensitive to MEK inhibitors. And in contrast, if the tumor is characterized by inactivation of DNA repair genes, they are associated with sensitivity to platinum-based therapies and PARP inhibitors, meaning if we have these molecular changes, we have more options for treatment. Therefore, our group recently developed a BRAF FISH probe, and for every single acinar cell carcinoma, now we are doing BRAF FISH analysis to identify the acinar cell carcinomas with BRAF rearrangements. And of course, FISH analysis is much faster and needs very little tissue. So our oncologists are routinely asking for us to do BRAF FISH analysis on acinar cell carcinomas. In terms of clinical course, acinar cell carcinomas are, of course, aggressive neoplasms, but when we compare them to the ductal adenocarcinomas, they are still better. Although they are commonly metastatic to the liver, 5-year survival is nowadays almost 50%. In the beginning, it was like almost half, but with the recent and better surgical techniques and more chemotherapy options, survival is much better. How about mixed acinar cell neoplasms? As I mentioned, these can be mixed acinar neuroendocrine, mixed acinar ductal, are mixed acinar, neuroendocrine, and ductal. And by definition, each component should constitute at least 25 to 30% of the tumor. Meaning, just because you are seeing a teeny tiny focus, like different focus, you can classify the tumor as mixed. Each component has to be at least 25 to 30%. Just like acinar cell, pure acinar cell carcinomas, these mixed acinar cell carcinomas are also ill-defined, solid and fleshy tumors with areas of hemorrhage and sometimes even little cystic degenerations. Morphologically, they show two different growth patterns. The more common growth pattern is characterized by this very homogeneous cell population, meaning each tumor cells is similar to the others, and you cannot identify the dual differentiation unless you do immunohistochemical stains. And when you do acinar and neuroendocrine markers, you see that cells are positive, same cells are positive for both markers. This is another example of mixed acinar cell carcinoma, acinar neuroendocrine carcinoma, composed of morphologically homogeneous cell population. But rare mixed acinar cell carcinomas actually have separate or like more distinguished components. In this tumor, we can recognize the acinar cell component in the center, and the neuroendocrine component is at the bottom and at the top. And when we do immunohistochemical stains, there is no dual differentiation. More acinar looking areas are positive for trypsin, and more neuroendocrine looking areas are positive for chromogranin. So this is a tumor with segregated areas of acinar and neuroendocrine cells. This is another example of mixed acinar cell carcinoma, but this time the second component is ductal carcinoma, not a neuroendocrine carcinoma. It's a ductal carcinoma, and you can see that on both H&E and special staining, the two components are intimately admixed. On the right side, the brown staining is trypsin and the blue staining is Alcian blue, and we can see how closely admixed the two components. In other areas of the tumor, the two components were more segregated, and this is a perfect example of segregation. This side is clearly a like picture-perfect ductal adenocarcinoma with gland formation and desmoplastic stroma, and this side is classical acinar cell carcinoma. Pancreatoblastoma. Pancreatoblastoma is a very unique tumor in the pancreas characterized by multiphenotypic differentiation. These tumors reveal acinar, ductal, and neuroendocrine components. Acinar component is the most common and usually the predominant component. It is usually seen in childhood, and in fact, it's regarded as the pediatric version of acinar cell carcinoma, but it can also be seen in young adults. So there's a bimodal distribution. Just like acinar cell carcinomas, serum AFP levels might be high, and these are also very large tumors. Mean size was reported as 10 centimeter. The tumors can show solid, nested, or acinar growth pattern, but at the end of the day, these are solid cellular stroma pure tumors, just like acinar cell carcinomas. As I said, acinar differentiation is very prominent, and it may actually lead to diagnostic problems, especially in adult patients, especially in small biopsies or frozen sections if you do not see the other component. Squamous corpuscles are very characteristic, and when you see them, you actually have no problem making the diagnosis. There are several squamous corpuscles here, and here we can even see orphan N-type nucleoli. And some squamous corpuscles actually show these keratinization as illustrated here. And as I said, when you see the squamous corpuscles on frozens or biopsies, you can easily make the diagnosis. Since these tumors have acinar, neuroendocrine, and ductal differentiation, they are positive for all these markers, but they also have abnormal beta-catenin expression, just like acinar cell carcinoma. But the beta-catenin, abnormal beta-catenin expression is usually limited to the squamous corpuscles as shown here. And finally, I'm going to talk about solid pseudopapillary neoplasms briefly, because these tumors, although they usually present as cystic lesions, technically they are solid tumors. So these are tumors of young females. They are usually seen in females in their late 20s or early 30s. And they are large tumors, and there are up to 30 centimeters solid pseudopapillary neoplasms in the literature. As I said, these are technically solid tumors, but usually they are like very hemorrhagic or degenerated, and therefore they present as partially or completely cystic lesions, as shown here. In fact, sometimes the degeneration is so extensive, unless you do total submission of the tumor, you may miss the very thin rim of residual neoplastic cells, and you may easily misdiagnose these tumors as pseudocysts. They reveal a variable cellularity. Some tumors are very cellular to the point they actually look like Ewing sarcomas. Others may be very sclerosed, as shown here. Of course, the characteristic histologic feature is pseudopapillary structures. These are called pseudopapillary because these are not real papillary structures. What happens is cells that are away from the vascular sources drop away, leaving a few layers of loosely cohesive cells around the vascular structures, creating this pseudopapillary appearance. Cytoplasms are usually eosinophilic, but in some areas it can be clear. Extensive hemorrhage in the form of blood lakes, as shown here, are common. You may also see histiocytes, sometimes like individually, sometimes as collections or cholesterol clefts, and even globules, eosinophilic globules, sometimes in large clusters, as shown here. These are made of alpha-1 antitrypsin, and if you do PAS stain, they would be positive for PAS. And finally, solid pseudopapillary neoplasms have very typical nuclei. The nuclei are very uniform, bland-looking, oval, and I don't know if it's illustrated well, but you can see longitudinal grooves. In a way, the nuclei look like coffee beans. And these are also very unusual tumors as well, because despite all these developments, we still don't know which cells in the pancreas are giving rise to this tumor. Therefore, their immunohistochemical phenotype is quite confusing, but please remember that solid pseudopapillary neoplasms are constantly positive for progesterone receptor and abnormal beta-catenin expression. And they are constantly negative for chromogranin, although less specific neuroendocrine markers such as synaptophysin, CD56, or NSC can be positive. So therefore, if you have a chromogranin positive tumor, and if you are considering solid pseudopapillary neoplasm, please consider again, please come up with another diagnosis, because what you have is not a solid pseudopapillary neoplasm. This is an example of nuclear progesterone receptor expression in a solid pseudopapillary neoplasm. And this is an example of abnormal beta-catenin expression, again in solid pseudopapillary neoplasm. Before we finish the immunohistochemical phenotype of the solid pseudopapillary neoplasm, I would like to mention one immunohistochemical stain, alpha-1 antitrypsin, because in our practice, in our consultation material, sometimes we see that people think trypsin and alpha-1 antitrypsin are the same thing, and they use alpha-1 antitrypsin to diagnose acinar cell carcinoma. However, alpha-1 antitrypsin is not same as the trypsin. In contrast, it's a very non-specific stain. It can be positive in a lot of tumors, including pancreatic acinar cell carcinomas and solid pseudopapillary neoplasms. Therefore, we do not use alpha-1 antitrypsin at all in the pancreas pathology. Please do not mix this alpha-1 antitrypsin antibody with trypsin. They are not the same. Finally, solid pseudopapillary neoplasms are indolent tumors, as their 10-year disease-specific survival rate is 96%. Basically, nobody dies from solid pseudopapillary neoplasm. And most of the time, they are confined to pancreas, but sometimes they can metastasize to liver or peritoneal surfaces. They are very rarely metastatic to the lymph nodes, but even there is a metastasis, the overall prognosis is still very good. These are indolent tumors. So this is the summary of the differential diagnosis of solid cellular stroma-poor tumors. So basically there are four entities: PanNETs, Acinar cell carcinomas, Pancreatoblastomas, and SPNs. PanNETs are usually associated with syndromes, histologically nesting growth pattern, neuroendocrine chromatin, and delicate vascularity are important clues, and they are positive for neuroendocrine markers. Acinar cell carcinomas are usually seen in elderly patients. Acidophilic granules, cherry red nucleoli, and frequent mitotic activity are important clues, and they are positive for trypsin, chymotrypsin, and BCL10. Pancreatoblastomas are usually seen in children, but they can also be seen in adults, so there's a bimodal distribution. Multiphenotypic differentiation and squamate corpuscles are important clues. Their immunohistochemical phenotype is quite extensive because they have different differentiations, so they can be positive for a lot of markers. And finally, solid pseudopapillary neoplasms are seen in young females. Pseudopapillary structures, macrophages, hyaline globules, and nuclear grooves are important clues. And abnormal beta-catenin and PR expressions, as well as no staining with chromogranin, are their immunohistochemical features. Thank you very much, and I'm happy to answer the questions.
Thank you, Dr. Basturk, for your excellent presentation. I can see a few questions online. So the first question is, how to differentiate high-grade PanNET from ductal cancerization in a biopsy?
So that distinction may not be possible even in resection specimens. If you see abrupt like transition from like benign and or normal looking lining epithelium to very exuberant proliferation, if there's an abrupt transition, that's usually colonization. But if the entire gland is affected, unfortunately, there is no way of knowing if it is high-grade PanNET or colonization. That is why studying the PanNET tree is a challenge for researchers, because you can never be sure what you have is a PanNET, high-grade PanNET or colonization. And you need cases where you see only PanNET tree but no invasive carcinoma, despite like submitting the entire pancreas, and those cases are extremely, extremely rare. In our series of thousands of pancreatic resections, we have like 12 cases with PanNET tree only.
Thank you. The next question is from Tim, who says that you mentioned that carcinoma looks more innocent looking when surrounding nerves and within vessels. Do
Yes.
you have a reference for this, or is it just an observation? And he also adds that it is something that I have published in gastric cancers and suspect it is a fundamental property of most cancers. Do you have any comment on that?
Yes, there are actually several review articles. I am not sure if there is an original study, but there are several review articles from experts stating this feature. And it's also my experience that when the carcinoma cells are in vascular spaces or nerves, they are usually like more gland forming and more innocent looking.
So the next question is it true that the TNM status of all resectable pancreatic ductal carcinoma is minimum T3N1? What's your view on that?
Well, in the past, yes, but nowadays our surgeons are very skilled. So even if there is like extension into the big vessels, if the involvement of the vessels is not like wide, they can do resection on so-called T4 tumors. It depends on the centers and surgeons' experience.
Right. And here's another question. Do you see any difference or morphologically between pediatric versus adult pancreatoblastoma?
No, there is no significant differences between the adult and pediatric cases.
And the next question is from Emmanuel. Have you considered metastasis from other sites, for example, neuroendocrine tumors not from pancreas, in the differential diagnosis of solid pancreatic tumors?
Yes, that is actually very common, especially for poorly differentiated neuroendocrine carcinomas. You have to exclude the possibility of lung primary first. Even for the well-differentiated neuroendocrine tumors, that is a possibility. For those tumors, actually, I forgot to mention one immunohistochemical marker, ISL1. It's positive in pancreatic and rectal neuroendocrine tumors. So that is always a possibility. Unfortunately, there is only one marker that can help us, and it's not entirely specific to pancreas either. So in that situation, clinical correlation is necessary.
Here's another question. What is your personal experience in utilizing SMAD4 in the biopsy diagnosis of pancreatic adenocarcinoma?
We use that in small biopsies. If the morphologic features are not obvious, we use that stain. And if there is loss of expression, which is seen in about 50% of pancreatic ductal adenocarcinoma, then we favor diagnosis of adenocarcinoma. If there is the expression is retained, unfortunately, it doesn't help. But we use that immunohistochemical stain, especially in biopsy specimens.
There's another question about biopsy specimen of neuroendocrine tumor markers. What is your suggested panel for neuroendocrine markers on a biopsy specimen if you have a doubt?
So if the morphology is not obvious, of course, we always do, even if the morphology is obvious, we always do Ki-67. And if the morphology is ambiguous, we do P53, RB, DAX, ATRX, and SMAD4.
Thank you. There is one more question. This is from Suma. So is there any cutoff percentage of components in a mean neuroendocrine and non-neuroendocrine? So what's the cutoff?
So each component has to be at least 25 to 30%. When you look at the AFIP, it says 25%. When you look at the WHO, it says 30%. But basically, substantial portion, at least 25%. Each component should be at least 25% to be considered as mean.
Okay, and there's another question, so which is about pancreatic adenocarcinoma. Do you have any criteria about adequacy of the biopsy specimen when you diagnose adenocarcinoma on a biopsy?
No, I mean, it's not the amount, it's the quality of the epithelial component. Sometimes we can diagnose even based on one gland, if it is like perineural invasion or vascular invasion. So there is no quantity cutoff. There's a quality or morphologic feature cutoff.
So how often do you correlate with the cytology specimen and the biopsy, including the cell block? So do you correlate before giving a diagnosis, or you just do it all by yourself? Standalone.
If it is positive, I don't care what cytology says. But if it is like wishy-washy, of course, we always consult with the cytology. And to be honest, most of the time, cytology specimens are more informative than the cell block, the core biopsies. So yes, it is not uncommon that we consult with the cytopathologist and compare specimens, unless it's obviously malignant.
Since you're talking about cytology, just one quick question. For pancreatic neuroendocrine tumors, are you grading them on cytology?
Yes, we are. Yeah. On cell blocks.
Okay. And what kind of biopsies are you getting for cytology? Are you doing like the shark core biopsies?
We have that option, but honestly, our clinicians are still using the conventional core biopsies, but shark core biopsies are definitely better.
Okay.
I don't know why they don't use it more often, but Yeah, it is available in our center.
And just one quick question: that 2016 paper for modern pathology, where it was between Sloan Kettering and Emory, and you're comparing the 4 counting methodologies. So you still use the manual method where you're printing the image and you're
Yes.
counting by hand?
Yes. For every single neuroendocrine tumors, our fellows know that they need to order Ki-67 and they need to print and count manually, and they bring that sheet along with the slides. And that's how we grade the pancreatic neuroendocrine neoplasms. And I know that in a lot of institutions, that is the method they use. Eyeballing is definitely not an option. You can use others, but eyeballing is no. And we use the manual counting for every single neuroendocrine neoplasm.
So no eyeballing,
Unless,
even
like,
if you're certain it's a grade 3. I mean, it's like 80%. I mean, do you?
Well, if it is 80%, you don't have to do it. But
Right.
most of the time, as I said, like in 60%
Yeah.
of the cases, it's close to the cutoffs.
Sure.
So, well, if it is a small cell, I'm not going to force our fellows to do that. But unless it's like less than 1% or like more than, let's say, 50, 60%, yes, they do count.
So sorry to keep asking about this. So in your report, you actually do give like a very specific percentage?
Yes, we give percentages like 24.3 or 16.5. So we give the exact percentage. And I would like to actually remind everyone here, thanks for this question, by the way, please do your best to give a specific number. Please do not say the Ki-67 is between 3% and 20%.
Right.
Because you never know what's going to happen in 5 years. Maybe
Right.
they are going to change the cutoff. And then actually there are studies showing 5% is a better cutoff than 3%. So in a couple of years, your report might be just useless if you give the, spectrum.
Right. Just having a range may not be good enough. Right.
Just do your best, and it doesn't have to be like 24.3, but at least say like 24%. Or whatever, like try to give a specific number.
I know that we're still a little bit away from having a lot of this stuff be automated, but what are your thoughts about? I mean, I know that in that paper there was some evaluation of an algorithmic approach to evaluating the tumor cells, and I mean it was using older technology, so separating Acinar cells from tumor cells from lymphocytes. It is challenging, but as we're all aware, right? I mean, that technology has changed and it has improved. What are your thoughts about potentially, revisiting that, right? And then having...
It is definitely better compared to, last couple of years. And I believe it's going to be even better in the near future. And ultimately, it's going to be the gold standard. But our concern was that, yes, it will be available in big centers, right? But it won't be available in small centers. So that's why we are saying that it is the most practical and also accurate for every single pathologist, regardless of their workplace. I'm not denying that technology is getting better and better, and it will definitely be much better than and easier than manual counting. But that's technology is not going to be available to every single practicing pathologist. So that's why we are advertising this manual counting, because let's face it, most of the pathologists have a camera in their offices, at least in their department, so they can do this accurately. Of course, if they have the fancy software, why not use it? I mean, I'm not against it, but the purpose of our paper was to make things easy for everybody.
Right. Thank you.
One practical question on that note. It might be possible that some of our colleagues in very remote parts of the world may not even have a printer attached to their computer, to their microscope, or they might not have access to a printer. What do you advise for them?
Well, I hear that there are some softwares online, not that I used any of them, and apparently some of them are even free, so they may try to download those and use those. And if that's not possible, I guess they'll just do, live counting.
Right. No, I mean, just in case. So another thing, on the same note, how much do you value mitotic count. So I mean, of course, we are doing KI anyway. Like, are we still putting a lot of value on mitotic count as well? Like, what is your approach to that?
So there was a study between Johns Hopkins and MSKCC a couple of years back, and we looked at the neuroendocrine tumors and compared to mitotic grade and the Ki-67 grade. And in the vast majority of the cases, Ki-67 was higher. In fact, there was only one case where the mitotic grade was higher than the Ki-67. And recently, Dr. Etsai and his team performed another study, and they actually showed that mitotic grade is like almost always lower, and we do not even need to count. And honestly, in practical, in daily practice, I don't even count mitotic figure anymore. I'm not supposed to say this as a WHO writer, but between us, we are relying on Ki-67 expression.
Actually, that's why I raised that question, because many a times I found that mitotic count might be less reliable. I mean, just from practical point of view, and counting the, like, because like we have all this criteria of how many 20 square millimeter and all these things. That's very, I mean, I find it impractical. And if we are anyway relying on KI, why are we wasting? I'm sorry to say that. Why are we wasting time on mitotic count? You know.
Now in daily practice, we basically don't count mitotic figures anymore.
Thank you so much. There is one last question I can see. This is from Vidya. Do you have any experience about perineural invasion in solid pseudopapillary tumor? And because I think they had a case recently.
Well, yes, they can do that. But I'm not aware of any systematic studies showing that perineural invasion is a sign of aggressivity. There are several cases in which mitotic activity was like very high, and there are two cases actually that showed like dedifferentiation. So those are basically more aggressive tumors. They came back with like metastasis, early metastasis and everything. But other than that, like other than very high mitotic activity and dedifferentiation, there are no other histologic features that can tell us the prognosis is going to be worse. But it can be seen, like perineural invasion definitely can be seen in solid pseudopapillary neoplasms.
Do you have any experience about extra pancreatic solid pseudopapillary tumor, just in case? Yes,
actually, was it Vikram? There is an ovarian solid pseudopapillary, primary ovarian solid pseudopapillary neoplasm. In fact, that case was an unknown case when I was a fellow, and I knew that it was a solid pseudopapillary neoplasm, but it was the very first case and it wasn't published. And I was like, I struggled a lot because I was thinking it cannot be solid pseudopapillary, it's in the ovary. But yes, there are rare examples of solid pseudopapillary neoplasms in other organs. Of course, we don't know if those are like indeed like arising from those organs, or maybe there was a pancreatic, heterotopia and the tumor was arising from that. We don't know yet, but there are a few cases. I think it was published, the first one was published by Dr. Vikram Deshpande.
Right. I think we have come to the end of the question answer session, and thank you again, Dr. Basturk, for this excellent discussion. And you have covered so many solid pancreatic neoplasms in 1 hour, and that's really helpful for all of us. And you would be so glad to hear that you had hundreds of viewers from at least nearly 30 countries from all over the world. And there were several viewers from Turkey who were writing a lot of notes in Turkish, which I am sure that they are complimentary notes. I of course, I could not understand. Sorry.
I'm going to look at them once we end the session.
And there were viewers from as far as Uruguay. A big shout out to Anna from Uruguay. I think we haven't seen people from Uruguay of late. Nicaragua, Italy, and Colombia, Nepal, Ecuador, to name a few. And of course, we had a lot of viewers from US and also from India. And thanks to our viewers for always supporting Patcast lectures. And please don't forget to follow our Facebook page and like our page, and also subscribe to our YouTube channel. So that is also a podcast, and also don't forget to subscribe to our newsletter so that you can stay updated with all the upcoming podcast lectures. So our next podcast lecture is coming up on Thursday, and our very dear friend Yelena Kresidinak from New York ME office is going to give a lecture on autopsy, and the title of her talk will be Importance of Autopsy Procedure in Pathology Residency Training. So stay tuned. That would be on Thursday, 8 a.m. Eastern Time. And thank you so much again. And thank you, Dr. Basturk, for joining us today.
Thank you, Rufat and Emilio, for the opportunity. And I would like to especially thank the, people who took their time to, join us. And I would like to mention one thing. Recently, Pancreatoblastoma Pathology Society actually published a special session in Archives of Pathology and Laboratory Medicine, and the experts in our field wrote excellent articles covering all the tumors I describe in my talk. So if they are interested, they can go back and check this special session, and I believe all the articles are free of charge. I highly recommend these articles. They are very great review articles.
Thank you again.